Good afternoon, everyone, and welcome to our External Consulting webinar series. My name is Tony Chiak, and I serve as the unit head within Management Engineering and Consulting. During this webinar, we will discuss Mayo Clinic's Opioid Stewardship Program. This program helps address the most pressing patient and clinical staff concerns about opioids at Mayo Clinic. First, I'd like to share some information about Mayo Clinic and our department, Management Engineering and Consulting. Here's some information about the Mayo Clinic enterprise. In Rochester, we see approximately 400,000 patients per year with 2,380 physicians and scientists, including 125 primary care providers. In the community and regional health system, we have it set up in 4 regions with 18 hospitals, and we are in 75 communities in Minnesota, Iowa, and Wisconsin. The Mayo Clinic Health System sees approximately 525,000 patients per year with 1,140 physicians. At our site in Arizona, we see about 115,000 patients per year with 621 physicians and scientists. And in the Mayo Clinic in Florida, we see 110,000 patients per year with 559 physicians and scientists. Now I'd like to share some background on the Management Engineering and Consulting Department at Mayo Clinic. ME&C was founded in 1947 and have been engaged in the healthcare consulting business for over 70 years. Our mission is to partner with clients to achieve the best patient experience through objective, innovative, and integrated business consulting. And our key capability is end-to-end internal and external consulting across practice, research, education, and administration within an enterprise setting. And here are a few details about our staff in Management Engineering and Consulting. We have approximately 200 team members made up of health systems engineers, project managers, and support staff. We pride ourselves in attracting and retaining a very diverse workforce. We've been able to attract diversified and talented staff that have lived and worked in 36 different countries. We also have a very multidisciplinary educational backgrounds, as you can see, with a lot of different experience in areas like business administration, nursing, organizational leadership, engineering, finance, economics, public health, and many other industries. We have 5 main service lines in ME&C. The first is Management, Systems, and Process Engineering, where we apply a variety of engineering tools to improve business performance, such as Lean Six Sigma, advanced analytics, simulation modeling, and optimization. We help integrate multiple disciplines to study and solve complex problems using a systems approach. The next one is Strategy, Design, and Execution. We help develop and refine business objectives, define key business measurements, and accelerate design and development of key strategic initiatives. The next is Change Management and Organizational Transformation. This involves vision design and development, change management planning, and implementation of best practices. The next is Revenue Enhancement and Expense Management. We work on business process redesign to decrease operational expense, improve supply chain efficiency, and identify new revenue opportunities. And our final service line is Project Management, where we utilize a structured and disciplined methodology project framework to deliver improvement plans to complex projects. Now I would like to introduce our guest speakers. Our first guest speaker is Dr. Halena Gazelka. Dr. Gazelka is a graduate of the University of Minnesota, where she received her MD degree. She completed her anesthesiology residency in 2010, followed by pain medicine fellowship in 2011 and palliative medicine fellowship in 2015, all at the Mayo Clinic in Rochester. She currently works as a consultant in both pain and palliative medicine and serves as the chair of the Mayo Clinic Opioid Stewardship Program. Our next guest speaker is Todd Ingram. Todd is the ME&C Project Manager for the Opioid Stewardship Project and is supporting the transition of the project to a long-term program. He earned a Bachelor of Science degree in Computer Information Systems from DeVry University. He has led multiple projects across a variety of disciplines at Mayo Clinic and has received multiple teamwork awards. Our next guest speaker is Danny Whipple. Danny is the lead ME&C Senior Health Systems Engineer with surgical specialties at Mayo Clinic. Danny earned a Bachelor's of Science degree in both Physics and International Business from Bethel University in St. Paul and a Master's of Engineering in Systems Engineering from the University of Colorado. Danny has led the successful design of many enterprise-wide surgical system implementations and has presented and received awards for outstanding quality improvement within surgery. Now I'd like to turn to Dr. Gazelka, and I want to welcome you to our ME&C external webinar series on opioid management stewardship program. And I want to start out by thanking you for your leadership on this project. I think without your leadership, this project wouldn't have been successful.
Thank you for having me
Yes.
here. Appreciate that, Tony. Great to be here today.
First question is, how did you get chosen for this project, and what gives you the passion to get up every day to continue to work on this?
Well, to number one, I have no idea how I was chosen for this project. No, I work in pain medicine and have a great interest in the opioid epidemic, and I chair our inpatient pain services. And I think that was probably the path to how I became involved and interested in this program. What was the second half of the question?
What just gives you the passion every day you get up in the morning to help fix this problem?
You know, the more I have learned about this problem, the more I've realized how prevalent it is and that it literally touches the lives of everyone in some way or another. And it's just, I think it's an exciting time to be working and to be trying to improve healthcare and trying to make a difference, and it is really exciting.
Great. So you were recently on C-SPAN and you testified before the Senate Health Committee. Can you talk about your work at a national level with this program?
Yeah, you know, that was a really neat opportunity, not one I expected to have, but came out of my work on the Opioid Stewardship program, obviously. I have been a member of the Health and Human Services Task Force that was implemented by the CARA legislation of 2016, the Comprehensive Addiction and Recovery Act. They asked that 28 specialists and professionals and experts come together and make recommendations for pain management at the federal level in federal agencies. And so we have just finished up that project and we're submitting it to Congress very soon. And that's kind of how I got involved in the work in Washington, D.C. I had met some Mr. Alexander staffer and was asked to do that, and it was a really neat opportunity.
Wow, that's great. Not too many people get that opportunity. Wonderful. So as you reflect on your years of work in this field, what surprised you most about opioid use at Mayo Clinic and also at a national level?
Well, I think what surprised me most about Mayo Clinic is I don't think we were necessarily a lot better off than many other places. We sort of think at Mayo Clinic that we want to think that we practice evidence-based medicine, that we do things the right way, but we had a lot of ground to make up as far as our opioid prescribing and our opioid stewardship. And I think that's what has struck me around the country, that every hospital, every health system that I've spoken to has a similar issue, and how do they grapple with it and manage it is the big issue. Also, how enthusiastic people are about actually affecting change, and I think that's been really gratifying.
Good, great. So Mayo Clinic is a very large healthcare system. We have multiple clinics and hospitals in the Midwest and Arizona and Florida. Now, did you see significant differences in opioid prescribing and usage across the sites, or did you see kind of common themes across the enterprise?
You know, that's really interesting. And as far as the specifics of our prescribing, we're going to get to Danny Whipple later, but he really knows those numbers better than I do. But what I would say is that the issues are similar. The state laws vary, so the regulations in those different areas vary, the laws that have been passed by the state legislatures, but we're all grappling with essentially the same issues. How do we take the best care of our patients that we can? How do we manage their pain appropriately, be it with opioids or without opioids?
Okay, great. So developing an effective structure and governance program in a large system like Mayo Clinic must have been very challenging. So how did you go about helping develop the structure here at Mayo Clinic?
I had a lot of sleepless nights the first 6 months before I met Todd. Actually, I had no idea how to go about that. The Mayo Clinic is an interesting institution in that we have lots of committees and lots of paths to get things done. And so a lot of what I needed was to figure out who do you go to, who gets things done, and what is the appropriate path to take to do that. And that is where, when Todd started working with our project, that he really made a difference because he already knew those things from other projects.
Great. So once you've implemented different programs and guidelines at Mayo, what do you use as metrics to really determine if you are successful in meeting your targets? And can you talk maybe a little bit about a control plan that you put in place to make sure that you sustain the gains?
Yeah, that's a really, really good question and a really important question. So the first thing we did is figure out that we had a problem. Danny helped derive all of those numbers, and we figured out that we really do need to change the way that we prescribe, but how do we know that we're doing it the right way, and how do we know that the result is right? And so part of what we're doing now is still deriving some of the results of those changes that we have made. In the future, we plan to have a program, as you alluded to. This project is becoming a permanent program under our quality office, and we will be using metrics from a dashboard in our EPIC program to help us determine how our providers are prescribing, how our patients are responding in terms of their pain, how the patients are being managed long-term who are on opioids.
Okay. The opioid crisis has affected many organizations and people in different communities around the nation. Can you talk a little bit about what Mayo Clinic is doing in partnership with their local communities?
Yeah, that's been a really important part of this because obviously we don't exist in a vacuum. We are a representative of our community. We're a rather large employer in our community, in fact, too. So we have partnered with the sheriff, the Olmsted County Sheriff, to work on some projects, including the DEA Drug Take-Back Day that occurs twice a year in the spring and in the fall. And we participated in 3 of those now and taken back over 2,500 pounds of medication, not all of it opioid, but destroyed it and gotten it off the street. We also have participated quite a bit in our local legislature and our state legislature. So I and other members of our group have spent time up in St. Paul speaking with our legislators. They've come here and met with us and asked for our ideas about the laws that they're passing right now that are being discussed. And we also have engaged in some community education projects and plan to do more of that. So working in the community has been an exciting thing too.
Great, good. So there are people on our webcast now, and there are probably people looking at it later that may work in smaller community hospitals. So if a medical director or administrator came up to you and asked you, how should we start addressing the opioid usage in our community? And once we do, how can we sustain that effort going forward?
Well, I think one important thing is to note is that I bet your prescribers are concerned about this too in your healthcare institution. I bet that they are aware of what's going on and of the extra scrutiny that has come to opioid prescribers and are interested in examining their practice. So I think examining the practice is probably the first place to start. Who's prescribing the opioids? Most institutions, it's primary care providers. The vast majority of opioids are prescribed in internal medicine and family practice clinics. Emergency departments also are significant prescribers, but not huge, and surgical services. So we do hundreds of thousands of surgeries here a year, and that is where we prescribe a large number of opioids. So examining the practice to find out what is going on so that you can look at what some of the standards are and see how your prescribers are matching up. And then find enthusiastic prescribers in those areas to help disseminate the work.
Okay, great. So we'll be hearing more from Danny and Todd later, but can you talk about the importance in your partnership with ME&C and how they've helped with the project management, the initial discovery, the implementation, and the control plan?
Well, I would love to, and if you'd like me to do a commercial afterward, I would. Actually, this is another of those things that kind of happened by chance. I literally was appointed one day to this job. I was told I will have a certain number of people working with me on this group, but I didn't really know who I needed. So I went back to my office and I was pondering this, and my husband is a physician here as well, and he shares my office. Our office, and he works on our spine redesign program, which your group has also been very instrumental in. And he said there's 2 things you need, 2 people you need. You must insist that you are given 2 people when you start this program. One is a project manager, and the other is a health systems engineer, someone who knows how to make things happen, and someone who knows how to keep everything organized, make sure it's all happening on plan. And that is the first thing I asked for. And I am telling you, it was life-changing. It's been great working with Todd, and then Kathy Gazelka has worked very closely with us, and it's really been amazing. I didn't actually know what their jobs were when I started working with them. I kind of had to ask them, well, what is it you do, and how do we work together? And so we went through a few bumps with that, just my ignorance, but it has been a wonderful partnership.
Great, good. Thank you very much. So all of us will become patients at one time and maybe get prescribed opioids. As health consumers, what questions should we ask our providers to help us avoid issues that develop if we don't follow the prescribing guidelines?
Well, we actually did a survey. Mayo Clinic did a survey last year of several thousand, just individuals in the community, not necessarily Mayo Clinic patients, and asked them about their preferences for pain management if they ever are in a situation where they need it after a surgery or an illness or an injury. 94% of people said that they would prefer not to be treated with an opioid if possible. They would prefer to have alternative treatments, including physical therapy, other medications that are non-opioid medications, etc. But only about 25% of those people actually talked to their provider about it or voiced those concerns. So I think a lot of times as providers, we automatically write a prescription. You've had this done, I give you a prescription, go home and sort of figure it out. And I think empowering patients that they can ask the questions, is this really right for me? What does this mean for me? What are the side effects of this? What are the risks of taking this medication? And what else could I have? Is there anyone else that you could refer me to who might offer me a different type of pain management to go along with the surgery or the care that you're giving me? Okay. And I think that's really important.
Great, okay. So what gives you the hope and optimism that the policies and programs under discussion at Mayo and across the nation will lead to breakthrough improvements in patient care?
Well, I think one of the things that gives me great optimism is the concern that everyone has surrounding this issue, whether it be the lay public, whether it be healthcare providers, whether it be legislators at the state or federal level, whether it be school teachers or law enforcement. Everyone is concerned about this topic, and they're concerned about it touching their family members, themselves, their friends. And I think that desire to improve this is what is going to move things forward. There are so many points and so many parts of this epidemic and what contributes to it and what needs to be fixed. But I think there are people in every one of those areas wanting to work and to improve it. And I think that's both exciting and I think it gives us hope.
So where do you think this program will reside at Mayo Clinic as kind of like its homes to make sure that we continue to look at it, monitor it, and make sure people are following the guidelines?
The plan is that we'll reside under the quality subcommittee of the Mayo Clinic Clinical Practice Committee. But we also have significant involvement in the Pharmacy and Therapeutics Committee because obviously opioid prescribing is a medication, and so pharmacy is appropriate. But we will be developing more metrics and monitoring what our providers are doing, but also how well they're doing. So we will continue to work here at Mayo, and it's an exciting time.
Okay, great. Well, thank you very much.
Thank you for having me. I appreciate it.
Your leadership on this, and we selected the right person to lead this project.
Well, you're very kind. Thank you.
Now I'd like to turn it over to Todd Ingram, who is the project manager for the Opioid Stewardship Program, and he's going to talk a little bit about the role of project management and the importance of it in these large, complex projects.
Great. Thanks, Tony. As you can imagine, Dr. Gazelka is a tough act to follow. But working on teams of Mayo staff that are at the top of their fields is both challenging and rewarding, right? Everyone from the physicians to the nurses to the pharmacists to the engineers, everyone on the team are experts in their field of study. And so they know how to improve the practice, and they also realize how to do that while keeping the needs of the patient first and foremost, right? So there's no lack of vision at Mayo, as you can imagine, right? So they know what to do. It's just how do we accomplish that task? So that being said, what I've tried to do is assemble some slides that really touch on the high points of the project management discipline and that really demonstrate how the ME&C project managers such as myself would engage with those subject matter experts and the multidisciplinary teams to really turn those visions and improvements into reality. So the very first slide is really related to structure. So one of the most positive benefits in my experience has been the ability to bring structure to the overall process. It's difficult to summarize all the various components of project management in a couple slides in a short conversation, but I've tried to touch on some of the key activities, methodologies, and techniques that have helped us successfully deliver the Opioid Stewardship Project. There are components of this work spread across all the phases of the standard project lifecycle, from initiation to closure, but we'll briefly touch on the following ones today. The project charter, stakeholder analysis, work breakdown structure, execution status reporting, communication, project closure, and then organizational change management. The figure on the right has been created by our Enterprise Portfolio Management Office and really represents a summary of the activities performed by the project management discipline. It has some additional details we won't cover in this discussion, but really demonstrates the depth and breadth of the activities that we support as the project management. So the next one is the project charter. Our project charter is really the cornerstone of the project work supported by ME&C. Typically, there is some initial discovery and analysis that's completed prior to engaging our PMs, but this is one of the most critical deliverables that's really prepared during the initiation phase of the project. It's developed in conjunction with the project sponsors and really serves as a framework for the overall engagement. It provides a standard and consistent structure for defining the areas listed. So there's the scope, a one-line summary of the project objective, something like improve opioid prescribing. The description is a brief summary of the project, 1 to 2 sentences. The objectives, then that demonstrates our alignment with the strategic and operational objectives for our department. There's the SBAR, which is another acronym we use here quite a bit at Mayo, that really provides some additional detail on the scope and description. The financials and the budget, obviously that lists the target financials and any known budgetary constraints. There's metrics that are listed there as well, as along with milestones for a key initial timeline and any kind of critical phases. And then the project team members, who are those key staff that will be included, including the lead physician, the administrator, the financial analyst, and health system engineers, etc. So the figure on the right is really just an example of the standard format used for the document, and you can see how some of the sections that we just mentioned. Color is typically used also to associate which sections are required for approvals, depending on which phase of the project lifecycle we're in: green for initiate, blue for planning, etc. The next one is stakeholder analysis. So that's another critical deliverable that's developed during the initiation phase of the project. It's also used to identify the key resources for the project and really helps to identify any groups or other teams or departments that could be affected by the project scope. This becomes especially critical when working with multidisciplinary teams in a large and complex organization such as Mayo. It also serves as direct input into the communication plan. So Mayo utilizes the archived model for summarizing the different roles that are defined on the project. So its first is accountable, identifies who has overall accountability for the project, who's responsible, identifies who is responsible for contributing to the activities. C is consulted, documents resources who are periodically involved for decision making. I is informed, identifies team members who are not in the critical path but informed on progress. V is veto, identifies who has the power to override or change decisions made by the team. And D is devil's advocate, who identifies resources for checking the counter arguments of any of those key decisions. So the figures on the right demonstrate that it's really a key deliverable early on in the timeline, but it's also leveraged throughout the complete life cycle. It serves as direct input into developing the project's organizational structure, supports status reporting, and helps identify the correct escalation paths for issue, change, and risk management throughout the entire engagement. Next is work breakdown structure. This is one of the most powerful and flexible tools that helps bring structure to any given project. And although typically not a formal deliverable, this work is generally used to identify the key task names, duration, start and end dates, key dependencies, and even project resources. This was especially valuable for the Opioid Stewardship Project since we had engaged multiple concurrent work groups, and it allowed the leadership team to have visibility into each one. It also served to communicate status and support the weekly status agendas. It's a powerful tool to examine the impacts of a potential change, provided the dependencies and critical path are identified correctly. So some of the benefits of the WBS are defines the critical project tasks, also known as the critical path, defines task sequence and dependencies, identifies the assigned resources and duration of the overall work effort, and also supports tracking of progress against milestones in the overall schedule. So the figure on the right is just a basic example of what it may look like. Obviously, depending on the project size and complexity, the level of detail and number of tasks will vary accordingly. It can be produced in a variety of formats and tools, depending on the needs of the project team, and the overall Gantt chart can be produced to visually display where the project is executing against the overall timeline. This was a really positive tool for the Opioid Stewardship leadership team to manage multiple work groups and manage them as really small sub-projects within the larger categories of effort. Next is project execution and status reporting. So one of the most important project management activities is status reporting. It's critical to be able to share the information, track progress, and keep the internal and external stakeholders informed. It was very important for the multiple concurrent work group efforts underway that the team was structured meeting agendas to keep on task and measure progress against their targeted schedule. Action items were tracked and reviewed on a weekly basis and to keep the opioid work on the forefront of the team's list of priorities. The team was able to leverage SharePoint as a document repository and a shared source of project documentation, presentations, and other work products. Regular, formal status reports were also completed on a monthly and quarterly basis for ME&C leadership and managed mainly through the Mayo portfolio management tool called Clarity. The figure on the right is an example of a status report. It contains a variety of information about the project and serves as an efficient means to quickly convey overall status visually through the use of stoplight notations, red, yellow, green. Red generally constitutes a negative variance greater than 10%, yellow is 5 to 10%, and green indicates on schedule. So the project status reports and summary data are reviewed also as part of a larger portfolio management effort by the ME&C leadership on a frequent basis. Next is communication and website. So the primary activity of a project manager within the Mayo Clinic enterprise and probably within the industry is communication. It's been said that project managers spend 80 to 90% of their time on a project in some form of communication, whether that's in preparation, leading structured meetings, documenting minutes and action items, updating work plans, creating status reports, creating deliverable documents, etc. This becomes even more critical when interacting and facilitating the project relationship between multiple interdisciplinary teams. Effective communication ensures that the information is provided in the right format, at the right time, to the right audience to get the desired impact. One of the successful tools developed by the project team has been our Opioid Stewardship website. It functions as a repository for many of the important work products produced during the life cycle of the project. It contains a wealth of information about opioid epidemic, policies, procedures, practice tools, prescribing guidelines, educational materials, and commonly used forms and documents. It also contains other links to other applications, such as Ask Mayo Expert, which is the online resource that provides Mayo-vetted medical knowledge and expert contact information for the point of care, as well as Epic, which is our new electronic medical record maintenance application. The website has been proven to be a very effective way to manage communication and sharing of information to a very large audience. So the picture on the right is the actual landing homepage of the Opioid Stewardship website and contains many of the content I just discussed. We also have a brief video message from our former CEO, Dr. Noseworthy, and we'll soon have one from our current CEO, Dr. Ferrugia. This is a visual testament to the importance of the Mayo Clinic Enterprise Opioid Stewardship Program. One of the specific criteria of a project is that it must have an end. So it's important to verify with the stakeholders that the scope has been completed, lessons learned have been documented, and the activities have been transitioned to long-term operations. This has been especially important as the Mayo Clinic Opioid Stewardship Project closes and transitions to a long-term program we mentioned earlier. It may sound strange, but some of the planning for project closure actually begins during project initiation. It's very important to understand the end state so that the team is prepared to successfully hand off the ongoing activities to the operational resources at the conclusion of the project. One of the powerful assets created by the ME&C team was the project library. This library contains a goldmine of prior projects and lessons learned that may be applicable to a new project that's initiated. Often there are historical projects that have been successfully completed in the same subject matter area and lists of contact names to collect more information. The documentation of the issues resolved, changes managed, and lessons learned can be invaluable to a new project starting down a similar path. So the team recognized the importance of completing the formal closure process and the related documentation. And the last one is organizational change management. Even though this is the last slide, it's really meant to cover the entire breadth of the project lifecycle. We've all heard the saying that the only constant is change. The ability of a PM and other project team members to react to that change and manage it successfully is critical to the project's success. Mayo follows the ADKAR model and methodology from ProSci. It's used to manage the people side of the change management, as well as applied to other areas such as organizational change management. Change can and does often happen through the entire project lifecycle. The ADKAR model can be broken down as the following. So it's on the right side, there's awareness, define the level of awareness needed to change. The desire, define the factors that affect the desire to make the change. Knowledge defines the knowledge needed to make and support the change. Ability defines the ability to make the change and remove barriers preventing it. And R is reinforcement, defines the organizational support in place to retain the change. The ADKAR assessment can be completed for a work group, project team, or an entire organization depending on the level of change management required. This is an integral part of the project management toolkit, and certification is also available from us from ProSci.
Great, thank you, Todd. You can tell we have a very disciplined approach to project management, and our service line is growing too. So thank you very much.
My pleasure.
Now I'd like to turn to Danny, who worked on a project in the surgical services area. Thank you, Danny.
Thank you, Tony, I feel privileged to share about our journey that I've had with Dr. Gazelka in conjunction with Todd on developing surgical guidelines for opioid discharge prescriptions. And just wanted to highlight a little bit about the environment which we found ourselves in when we started this project. And so we really worked in parallel, and I think it's important to understand that that we could not have been successful in surgery apart from Todd and Dr. Gazelka's work that was happening simultaneously in the larger space of the enterprise. And so as you can see on the next slide, there's a lot of external pressures that we found ourselves in when former CEO Dr. Noseworthy came to us and said, we need a plan for how we're going to manage opioids at Mayo Clinic. And so on the top you can see where Todd's pathway in his project management was occurring, and simultaneously surgery was also then approaching how we can assess the problem, where we're at, and the direction that we need to go to rein in and our opioid prescribing and come up with standardized guidelines that could be applied across the enterprise. And so some of those external pressures you can see, state statutes, federal mandates. We're also seeing insurance coverage starting to implement caps on prescribing where they would not cover over, and every insurance company had a different policy. We're starting to see that. And then, as Dr. Gazelka highlighted, we were seeing a change in patient expectations. And so I think most can agree that we kind of found ourselves in this situation based on patient experience, HCAP scores, and patients wanting to be satisfied. And now we were seeing a shift really in what patients were wanting. Like Dr. Gazelka highlighted, 94% of the patients saying that they wanted to be able to avoid narcotic pain treatment. And so when leadership came and asked for a plan, it was just important for us to be able to work in parallel with Todd and Dr. Gazelka's group, because surgery is an island. There's lots of possibilities that can introduce opioid prescriptions outside of the acute surgical episode. And so that parallel processing is key. We chose to use the DMAIC methodology as this project really fit a well-defined quality improvement approach. And so what I want to highlight is how, as a health systems engineer, we approached that. And first was really defining what the problem was. And with so much visibility, growing visibility with the epidemic, it was hard to kind of wade through the noise to identify what the true problem was. And what the question we're asking is, are we meeting the pain management needs of our patients without introducing risk? And by that definition, what does risk mean? And what we found was that the problem really was a case of overprescribing opioids during an acute episode, which can introduce excess opioids into the population and increase risk of dependence on that medication. And so our target then, as you can see, is a theme that went into all of our guidelines for surgery for each department. When prescribing opioids, selecting the shortest acting, shortest term, lowest effective dose for that patient's episode. And so the work then began to identify what are we doing currently in that space, and what does the appropriate prescribing look like? Things as the insurance companies and legislation was coming out with, there was just OME numbers, and some were 90, some were 120, some were 50. They were talking about just capping the days of prescribing. There was MEDD, morphine equivalent daily dosing caps. And so trying to wade through all that talk and figure out really what is the best approach for our patients. And again, as we go back to coordinating with Dr. Gazelka and Todd's group, is looking at all the other factors that play into possible prescriptions for that acute episode, such as readmissions in the ED or that primary care physician, which oftentimes for Mayo patients is not here at Mayo Clinic. They're going home to their own primary care providers. And so when we look at pulling the data, we really needed to have a target change specifically. So if you think about SMART goals, you're looking for specific, measurable, attainable, and having target ranges. And so we targeted our highest prescribers first in the surgical practice and decided that the best offense is a good defense. And so, again, what we're targeting is curbing the opioid dependence that comes through excess medication. So if we can target naive patients, which are a little simpler to understand from a prescribing pattern, we'll start with that. So that's what we targeted first, was naive patients, meaning that they did not have opioid prescription in the previous 6 months as they came in for their surgical encounter. And then we looked at trying to understand historically what our prescribing patterns were and look for patterns that came out in that information. So looking at 30-day post-discharge prescriptions in terms of oral morphine equivalent per CPT code. So in this example, you can see CPT codes A, B, C, D. We were looking at the mean, medium range of prescriptions that those patients had 30 days post-op. So that's everything from when they were discharged continuing forward 30 days. And what you can see is, in terms of patterns, is you can see a large variation in range. So some patients getting 0 opioids and some getting larger prescriptions for opioids. And then we can also see a pattern of overprescribing, where in all cases here, patients were not using all the narcotics that they were given. So looking then at that data, now understanding kind of the patterns that we have, when we start to analyze it, we created a current state map of just how are those opioids being prescribed. And as we look across the different surgical departments, everybody has a different approach in practice. And so sometimes residents are writing those prescriptions, and sometimes it's the physicians themselves, and then how that patient's being discharged, how they're being told about their pain management plans varied. And so that's where, again, working in parallel with Dr. Gazelka and Todd's group to understand what the larger model is of standardized opioid prescription would look like. And then we highlighted some gaps. As you can see here, we're looking at ordering templates. So in most systems, they're going to have templates that they can use to simplify creating your discharge order sets. And those orders can be carried on. And so as residents would change, rotate through, they would be handed kind of the order sets that's been used previously. We also have written order requirements, so, and then closely in conjunction with the non-local patient subset, we have a lot of patients that aren't local that if they run out of opioids and they're still in quite a bit of pain, they're needing a written prescription to be able to continue some sort of pain management. And so that creates quite a complex system for what may be caused overprescribing to allow patients to have enough to get back to their home on the West Coast, without needing to fill a prescription on the road, that type of thing. And as I spoke to earlier, HCAPs were really driving ensuring that patients had a good experience. And sometimes I think that came to be known as no pain. You know, you're getting a new body part placed within you and really expecting to not experience too much pain during that. And so now that patients are becoming more engaged and are aware of the risks of dependence, I think that's becoming an easier hurdle to overcome. And so then the other bullet point we have here in Analyze is that we had in our multidisciplinary team, we have providers that are on the state level. We had Dr. Gazelka that's on the national level, as they're talking about creating legislation about how opioids are managed. And we wanted, again, best offense, the good defense, providing them data to help them make data-driven decisions about what is best for the patients. And with Mayo Clinic, we just have such a high volume of patients that we're able to provide that data quickly. On the next slide, you can see what our guideline actually looks like. So what we ended up coming up with is a list of possible CPT codes and quantifying them in terms of tiers of opioid recommendations, and breaking it out by the types of opioids that are most commonly prescribed. And the goal here really is making the right choice the path of least resistance. So while we weren't able to create guidelines that included every CPT code that practice may be conducting, giving them a really good idea about what category their patient would fall in terms of opioid prescribing. And so when we move to implementing this, again, just like Todd highlighted, using the ADCAR model, because it really is creating effective change management. And so you need to understand the stakeholders that are involved and begin with setting pain management expectations. And so that includes both pain management expectations for the staff and for the patients. And then we also utilized tools to then support making the right decisions. Education in terms of making sure that stakeholders understand their role in the process, and that's from the beginning when that patient's at their surgical consult and setting an expectation for what pain management would look like, as well all the way through the discharge when their nurse is helping them exit their hotel or their hospital room, and giving them the tools to be successful in creating just an acute episode for their pain. What it looked like in a process is here are outpatient settings, creating that expectation for the patient, providing the tools necessary for that provider, APP, or resident to discuss with the patient before their discharge what their expectations should be for management, and that their pain should be getting better each day, and what that tapering type methodology would look like for their pain management. What this looked like in a more systematic view is in our EHR system is this process flow here. And while it's busy, I just wanted to highlight, we're asking the first question, is the patient receiving homegoing medications? If so, we're providing the ability for the provider to look to see if this patient's at risk for dependency, and then towards the end of that process, providing both the providers writing the prescriptions as well as the patients the proper tools to be able to manage their pain effectively and reduce their risk for opioid dependence as much as possible. And then creating a control plan, as Todd alluded to, very important. We do have dashboards that allow providers to see even their patient subset and how their patients are falling into their opioid prescribing. You can take that up and see which departments are affected most, which are maybe lagging behind. Creating awareness so that providers can easily identify patients that are already on maybe chronic opioid users, maybe seeing as you're writing discharge prescriptions for an acute case, also noting that they have existing prescriptions, from primary care, whatnot, as well as providing, again, the path of least resistance for doing the ordering process, providing ordering instructions, again, highlighting, creating awareness of maybe other orders that are out there and the morphine equivalent daily dose, providing indications that helps bucket the patients into appropriate duration of time for their opioid prescriptions, as well as ordering templates. Again, we highlighted as one of the gaps is that the templates couldn't just be saved for an arbitrary number of opioid pills. And then providing the care model, which is part of our Ask Mayo expert system that's available to practices that are in our Mayo Clinic network that provide a process flow for getting providers to the right place of what type of considerations they need to make when doing writing prescriptions and the appropriate levels. So.
Great. Thank you very much, Danny. That was a very comprehensive approach to surgical problems. Looks like we have a few questions here. This one is for each one of you. So, in reflecting on your experience over the past couple of years, is there anything you might have done differently? Any additional lessons learned that you can share today? Maybe we can start with Danny.
Sure. I think something, I saw there were some other questions similar, is that oftentimes from a systems engineering approach, systems engineering methodology can apply to any situation. And so if you can focus on defining the functional requirements really of what you're trying to do, those functional requirements can be adapted to fit any type of model. And so those familiar with Mayo Clinic know we have a complex model with health system sites as well as sites operating in different states with different capacity, with different providers operating in different capacities. And so I think being able to come up with a system, again, we targeted our highest users, but we do have opioid guidelines for every surgical practice at Mayo Clinic across the enterprise. But the how that was done, who's delivering the messages to patients, we have nursing templates that have taper plans set up for that they can give to patients. That's different in different practices. So creating a higher level functional system that then can be adapted to fit any model. It allows you to keep your standardized approach, but with enough flexibility to fit different practice needs.
Good. Todd, anything from a project management perspective?
Boy, yeah, looking backwards, there are always things that you could do better and improve, and I think we'll all echo that comment. But I think the one thing that, just because it's the most recent, has probably been the struggle with the where this is going to land and operate long term as it transitions into a program, and understanding the Mayo structures and the organizational teams that have to be included in that communication to get that finalized. I think I wish I would have done a little bit more lead time on that and focused on that a little bit further. But because I think that would have helped us in the long run and shortened up that timeline, because we've had to extend the overall deadline for the project to accommodate some of that change in organizational structure. So that'd be one area what I'd like to focus on. If I had to do it again, it'd be earlier.
Okay, great. Dr. Gazelka, any lessons learned or things you
Well, I would get these guys working earlier. No, actually, they were with us almost from the beginning. It was fantastic. I think getting the right people involved. The first year of the project, and Todd can attest to this, we had a lot of people around the table, but we had a few people doing the work. And so it took us a while to figure out how to divide up our work and how to delegate the projects in order to get the work done, and also to shed some of those who really were not interested in working on the project at that time. I think one of the things that we did marvelously well, and Danny was very involved in this, is in enlisting the interested parties. So I was very concerned and would lay awake at night about how was I, as an anesthesiologist, going to tell the neurosurgeons or the orthopedic surgeons that they needed to prescribe fewer opioids. Thank you very much. And the emergency room, the same thing. Well, by enlisting people who worked in those areas, by having an orthopedic surgeon be our first person to say, I will do this in my department, And we've used the same model through all of the areas where we've gone. There's been a champion in that area. And now Tad Mabry, that's the orthopedic surgeon, has worked at a state level with me on opioid prescribing guidelines for within the state of Minnesota. And so that's been really gratifying. I think that's been really helpful. Same thing in the emergency department. Casey Clements is a physician who's been vital to our work on the Opioid Stewardship Project, and he's an emergency medicine physician with a passion for this. 3-day limits. No one can have more than 3 days of opioids coming out of a Mayo Clinic emergency department. And so getting the right people, I guess.
Good, great. Okay, so from a project communication, it's really important to have that. What media methods did you use to keep all the stakeholders at Mayo Clinic informed on the project? And I can open this up to anybody here.
Well, I can lead off, and it's really any tool. I mean, we used everything from our opioid website we showed earlier to emails, phone calls, periodic video conferencing. I mean, we use whatever tools were at our disposal to be able to share that information and keep everybody in the loop and up to speed. So I think all of them that were at our disposal, we use just about every format I can think of.
And what I would add to that is Ask Mayo Expert within Mayo Clinic has been the general repository of where we've kept the most vital parts of the information, the prescribing guidelines, et cetera. But this actually was a source of, occasionally, of sort of frustration for us that we had all of these modalities to provide information. We use the news network at Mayo, the communications people, we used email blasts, we used everything that we could think of, and still we hear from people, is anybody doing anything about opioid prescribing at the Mayo Clinic? So I guess it's trying to find people where they are, and it is a bit challenging, but we've certainly tried to cover every avenue that we could.
Probably should have used Twitter. No, I actually wish we had something more advanced. In person seemed to be the most effective. And again, like Dr.
Yes.
Gazelka highlighted, once we identified the stakeholders for each department, we would generally have one meeting where we'd meet with the stakeholders, and by that I mean pharmacy, nursing, and a provider for that department. That's all it took. We were a really agile team. We were able to make decisions rather quickly, and so really, I think in about 2 in-person 1-hour meetings, we were able to identify historical prescribing patterns and develop the goal for that department, and then move on to the next department. So this
Really
is a
good point.
a good highlight of just identifying your stakeholders early on, so that you know who needs to be there, and it allows you to move very quickly.
Good, okay. This one's for Dr. Gazelka on the study referenced earlier about the 94%. So was there a breakdown by demographics? Younger people want less, older people want more opioids. Is there more you can share about that study?
Well, that's interesting. I'm not aware of a breakdown by demographics, but it has not, we always think, well, maybe it's younger people who are more interested in opioids and older people who fear them more. I'd say anecdotally in my practice that's probably true, but I think that the awareness is there for every age group. Other points of that study were that 67% of people recognized that the risk of addiction on opioids, but only 37% of them felt that they might be at risk for that addiction. And so I think a lack of education, and I think that's where we can help in the community by educating patients that the risk, is similar for all of us, that we know right now that discrepancy isn't known. So it was a really interesting study.
Good. Are there specific resources at mayoclinic.com for patients on how to speak with your doctor on narcotics or opioids?
There are. That's a really good resource for reading about opioids and for reading about some recommendations for alternative pain management strategies as well.
Okay, great, good. So next question is, as a patient, how can I tell if my physician or healthcare organization is practicing good opioid stewardship and I do not have to worry? Is there a certification or way to find out from public information?
Danny, do you have anything to comment about that? You look like you were thinking hard there.
Not that I'm aware of, but I would think that it would be important to see an organization having a stewardship plan in place is what I think,
And
look for. And I think providers should be willing to, I think patients will be finding providers willing to talk about this much more than they maybe have in the past.
That's a really good point, Danny. I think the other thing is that when the prescription is handed to the patient, how is it administered? What are they told about that prescription? And I think how their individual provider discusses opioids with them is vitally important. We did a study in the hospital where we had pharmacists actually sit down with patients and provide them education at the end of their hospitalization, rather than what would typically happen, whereas they get all this paperwork from the nurse who's getting their discharge summary ready. They're handed prescriptions, several of them. Okay, here you go. Here's your pain medicine. Go fill it. But in this case, they had pharmacists sit down and describe for the patients when to use opioids, what they are, what they're useful for, what the risks of them are, concerns about constipation, concerns about nausea, et cetera, and how to get off of them, how to minimize use. And I think an organization that stresses that kind of stewardship, or a provider, individual providers sometimes can differ within an organization as well, and I think that's an important thing to seek out.
Okay,
In our
great.
surgical departments, we do provide patient education on pain management. So I just encourage
Yes.
patients, if they, again, from a surgical perspective, if you're talking with your surgeon, I would ask that question if they don't already bring it up of what can be my expectation for my pain management, both in inpatient and homegoing.
Okay, great. Current trends in healthcare seem to revolve around artificial intelligence and machine learning to help physicians. Do you or have you seen a role for AI in helping address the opioid concerns?
I would actually, and I think sometimes we're limited by implementation technology, but we see pretty clearly defined trends, I think, in risk aversion for developing dependency and those types of things, and the more that data is available within the record, and the more we can leverage that data actually to, I could foresee a future where basically an order is being populated based on risk stratification. And again, historical use. So again, we're in really phase one, these guidelines that we've developed, and we hope that we're going to constantly be adjusting them as we hone in on really what the right number of pills is going to be for a patient, which can vary again by not real difficult factors, age and such. So I think that's a direction that I could see us going. But oftentimes you're limited in the data that you have and how to use it, and so I think that's where we can use lots of great thinkers on how to best leverage the data that we do have. Again, I think it's easier to find trends in the data, but getting those into, again, make path of least resistance for providers to be able to make the right decision will be important.
Good.
I have nothing to add to that.
All right. This is maybe a question for you, Dr. Gazelka. Are there any additional myths about opioids that you'd like to dispel today?
Oh, wow. Well, I think the most important thing that I'd like to share is that opioids are great medicines. They're really important medicines. They've been around for 3,000 years, and there's a reason for that, because they work for pain. They're truly the best pain medicines that we have. And so there's a purpose for them, and they're not to be banned. They're not bad for people. They just need to be used wisely. So the right medication for the right patient at the right time. Patient-focused care.
Good. Let's see if there's any other questions. Looks like there are no more questions. So I want to thank my guests today for taking the time out of your day to be with us.
Pleasure.
And I want to thank the audience for attending our External Management Engineering Consulting webinar. And please feel free to contact us by calling us at 507-284-3424 or visiting our website at ME&C.mayoclinic.org if you have any questions about our external consulting services. Thank you very much for spending your time with us today.